Good morning.
Good morning.
Good morning.
Good morning.
I guess it's too early.
But it's Friday.
Yeah. I am hang on. I was trying to figure out how to pull up more than one thing at a time. I'll just show you after this, but I revised the updated course calendar, and I mean, it's kind of a moot point now, but I had updated it and was going to show it to you. But if I forget to show it to you, I'll post it after class. So I just want to skim through the rest of physical assessment and then talk to you about what's next and look at chapter 35. I don't know if you noticed or not, but part of the revision was that I cut chapter 36. I took that off. So you'll see on Canvas, the headers changed. Instead of 35 and 36 for this week, it's just 35. The PowerPoint's pretty self-explanatory. You've got my notes on there, but we'll try to go through it real quick together, and then you can look at it in more detail by yourself. So I think this is where we left off on the physical assessment recording. Is that right?
Yes, ma'am.
Okay. So basically, whenever you walk into a room to do an assessment with a kid, it's not so straightforward where, you walk in and introduce yourself and get started, because you have to try to keep the kid calm, right? Or you won't have any kind of cooperation, and you have to gain the trust of the family, and the child needs to see you gaining their trust and all of that. So, some of this we've talked about before. Do you start head to toe? Do you do toe to head? Do you listen first? What do you listen to first? All of that comes with judgment, your own personal judgment. And I've had some students that have already recognized this in clinical. If you just go in the room and introduce yourself and start visiting with the family, if possible, and making some kind of effort to interact on a developmentally appropriate level with the child through play or conversation, then your assessment will go much smoother. You've got to consider stranger anxiety, and a lot of times distraction techniques are the place to start instead of just jumping in with your stethoscope. But when would that not be okay?
In an emergency?
So how do you know if it's an emergency?
Like airway obstruction or anything to do with them like not breathing?
Or they just don't look good. Like they seem not even necessarily an emergency. What if they seem like they're in pain, or they look like they're about to throw up, or they're diaphoretic? So sometimes we have to forego the social, making sure everything's hunky-dory and just jump right into our assessment. So that all depends on the patient and on your judgment. Everything that the book says as far as where to begin is just a suggestion, other than the fact that you save the painful assessments for the end when possible. And you, if they're quiet, you need to listen to them first. As far as babies that are crying and things like that, that just makes sense to listen to them and get good breath sounds and heart tones and bowel sounds before they start crying. But always assess painful areas last. If it's a new admission, what do you need? There's a couple of things that you need right off the bat, but picture a new admission walking into a room. Do you immediately get them hooked up to the monitor and get your admit vital signs? Do you immediately put your stethoscope stethoscope on them? Do you immediately put them on a scale and get their weight? All of those things need to be done, but what do you do first?
I would check respiration. Make
I
sure
would
that-
gain their trust first so it's not like a horrible experience. Sit down and talk to them for a minute.
Ask them what.
So was that Chris talking before Monica?
Christina.
There was a guy.
Hey, Stephen.
Stephen. So it depends. All of you are right, but it depends. You should gain their trust first, and we do that when we can. If it's obvious that the child's not in immediate distress, then we do that. But say you work in an emergency room or in an ICU, and it's a given that there is potential that the patient is going to be in distress. Right off the bat,
And
somebody,
vitals.
yeah, well, it's usually the best scenario is that it's a group effort. But if you're by yourself, I think that the best thing to do, especially with a kid, is to assess work of breathing and put a stethoscope on them fast. And then you can just assure yourself that they are moving air. Now, that doesn't take more than a few seconds. At the same time, you're introducing yourself and you're hooking them up to the machine to get vitals or manually getting vital signs. So, I mean, you can see that it's such a variety of, there's no black and white rules with this. If the kid's okay, then yeah, your day's going to be a lot better if you gain their trust first. But what if they're not okay? And how do you know if they're okay? What if they're on the verge of going bad? You have to recognize, are they sick and how sick are they? Obviously they're sick if they're in the hospital. So when I say, are they sick, that means, are they super sick? Are they on the verge of having compromised perfusion or compromised respirations? You know what I mean? You can have a kid that's sick that needs to be in the hospital for antibiotics that's perfectly fine. Somebody tell me you understand what I'm saying.
I
You
do
can be-
understand.
Yeah,
Yes.
you can be sick and be perfectly fine, or you can be sick and be in trouble. So your job is to look from the door and say, are they sick and how sick are they? Because that tells you how much time you have and how much time you can waste. What vital signs are we going to get?
I would get their temperature, their respiration. Forgive me, I actually haven't
That's okay.
read the chapter, but
okay, just-
I've heard you're not supposed to do blood pressures on kids under a certain age.
So it depends on the facility where you're working. When we first started doing clinical at South, we only got blood pressures on children on admission and if ordered after that. Then when we had a new intensivist join the PICU team, when he found out that we weren't getting routine blood pressures, he did not approve or agree with that. And he had our policy changed on the peds floor. So now we get blood pressures every 4 hours. And, so we get them routinely. I see both sides. In the ICU setting, of course, blood pressures can tell us a little bit more information than they would on the floor. And that's only because a child's blood pressure should reflect their cardiac output. A child with compromised cardiac output should not be on the floor. So if I assess a child and they have a cap refill less than 3 seconds and palpable pulses, good urine output, their neurostatus is intact, all of those things that represent perfusion are good, then their blood pressure is good. And when many of my students have already seen, when we try to get blood pressures on young, healthy patients, a lot of times we get falsely elevated blood pressures. We get numbers that are all over the place because they're crying and kicking, but it can be done correctly. So it just depends on where you work, on what their policy is. But you're right, it's not unusual that you see blood pressure skipped, especially if they're younger than 3. So respirations, heart rate, temperature, blood pressure, pulse ox. We get all 5 things every 4 hours. The most accurate blood pressure reading is using the right upper extremity. And we are always supposed to document where we obtain the blood pressure. It is often difficult to get the cuff secure on the right upper arm without upsetting the child. It's much easier on the little ones to just put the cuff on their lower extremity around their calf, and that's fine to do as long as you can get a number that is within normal limits. If not, then you need to let them calm down, reassess, and use the right upper extremity, or the nurses will ask you to redo it. Okay. So this slide is just talking about what I already mentioned, the first impressions. Are they sick or are they okay? Are they developmentally age appropriate? That's stuff that you recognize right off the bat when you walk in the room. As soon as you open the door, you make a first impression, and you probably haven't been giving yourself credit for that impression. What I mean is, you open the door and are they awake or are they asleep? If they're asleep, do they look like their heart is beating? Are they alive? Do they have perfusion? Are they pink? Are they cyanotic? Are they pale? Are they sweaty? If they are awake, do they make eye contact? Do they respond to you appropriately? Does the 10-year-old act like a 10-year-old, or does the 10-year-old appear to be more like, a 1-year-old in the crib with obvious developmental delay? So you may need some historical information, but sometimes that you always need historical information. You've got to ask the family questions and things like that. But at the same time, you, depending on how sick the child is, that may have to wait. That's your call as to if you jump straight on your assessment or not. Move this up a little bit. So the chief complaint, determining the chief complaint. Onset, duration, characteristics, blah, 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 blah. How do you word these things in common language? What do you say? Can you tell me the onset of your chief complaint? Is that what you say to your family?
No, I would just ask them what brought you here. If the
Right.
child's old enough, I could say, where does your tummy hurt, or how long has it been hurting?
Right. And has anyone else in the family been sick? What makes it, has anything made it get better, or has it just been consistently the same? For example, if they told you laying flat with their legs stretched out makes their stomach hurt worse, and if they curl up in a ball, it makes it better. Exposure to infectious agents, I guess, would be the only other main thing here. We've talked about this before, characteristics of the chief complaint. This is just where you say, just like Monica was saying, so what happened? What brought y'all to the hospital? Tell me what's going on. And the point here is, what happened that made this illness get so bad that you end up admitted to the hospital? So yeah, we know that your stomach started hurting on Sunday night and he was throwing up. Say that's all they give you. Okay, big deal. You could have gone to the quick care for that. How did they get admitted to the hospital? Something more happened. So we have to, how on the last test it talked about beginning with open-ended questions, and that's what we just did. But then if then you have to clarify and get more specific. When they give you a vague answer like stomach ache and vomiting, then you clarify. So, then what happened? How many days was he vomiting for? Was he keeping anything down? So when you went to the emergency room, did they say he was dehydrated? And you have to kind of dig around and piece things together sometimes. As far as the past health history goes, prenatal history, what can you think of there? Prematurity.
Yeah.
Yeah.
How was the delivery?
Right.
Complications,
I mean,
breastfeeding?
the doctor's going to ask a lot of that stuff when they get their information. But as far as what I'm concerned about is, were they full term? Were they in NICU? Did they have any problems? Because whether they were premature or full term, they could still have had problems related to delivery or prenatal issues. So I just want to know, is there anything that happened around the time of delivery or in utero that could affect the child now? What kind of past illnesses have they had? Had they had surgeries before? Have they ever been in the hospital before? That's something that jumps out easily to me, especially if I'm taking care of a kid with asthma, or even pneumonia, just any kind of respiratory illness. One of the first things I want to find out is, have they ever been in the hospital before for this sort of thing? Because that tells me something about their ability to that's not the word. Their ability to deteriorate, I guess. Their ability to get sicker than the average Joe. Most kids don't get admitted to the hospital, period. And if I've got a kid that has been in the hospital 3 or 4 times in their short little life for asthma or pneumonia, if it's asthma, then I understand they have a serious case of asthma. If it's pneumonia, then I start wondering, were they a preemie? What kind of lungs are we dealing with? If they weren't a preemie, then why? Do they have immune problem, immunity problems? What's going on? Do they have cystic fibrosis? What's going on that I'm missing here? Of course, their allergies and diet status, medications that they're on at home. It's kind of the main stuff. So let's look at a question. You're ready to start your exam on an 8-month-old infant who is sitting on mom's lap chewing on a toy. What do you do first? Reflexes, heart and lungs, eyes, ears, and mouth, the head, including the fontanelle.
Heart and lungs.
Heart, lungs.
Y'all agree? Oh, I should have done a poll, but I don't want to run out of time. So let's see. Yes, the heart and lungs. Yeah, if they're being good, you got to get that knocked out. Now, I could hear someone say, yeah, but you said that when you first walk in the room, you pat them on the head like a dog and fill their fontanelle. Well, yeah, that's true. But in this situation, the best thing to do would be heart and lungs. Maybe while I'm listening to their heart and lungs, if they're allowing it, then I'm using my other hand to give them a pat and scratch behind the ears. So we know that we're going to approach them according to their developmental age. As far as the proper place for the exam, do you lay them down on the table? Do you take them away from their parents and lay them down on the table? Do you let mom hold them or let dad hold them? It's perfectly fine to leave them in the caregiver's lap for the majority of the exam. If there is something that you are unable to assess and you really feel like you need to lay them down, just save that to the end and lay them down if you have to. But I mean, I can't, I'm trying to think of something like that I would need to take the child away from the parent. Maybe assessing a wound or something, but still in most cases, the parent can reposition them and hold them in such a way to help you be able to get a good assessment of whatever body part you're trying to get. Usually taking them away from the parent is just going to make life harder. Okay. So For example, assessing our babies. Let the caregiver hold the baby. You know you're going to listen to everything you can while the baby's quiet. While you're listening, go ahead and count your heart rate and respiratory rate. What can we do for our heart rate on the babies? Somebody that's had clinical with me.
6 seconds. If they're
6
resting.
seconds. Yes, 6 seconds times 10. So if you look at the clock and you count that fast heart rate for 6 seconds and you get 13, you can multiply that times 10 in your head. No matter what number you get, you can multiply times 10. All you have to do is add a 0 to the 13. And you would get 130 for your heart rate. So you got that knocked out. You listened to the heart rate. You heard S1, S2. You didn't hear a murmur. Now you're counting your respirations while your stethoscope's still on them. You've listened to breath sounds. Count your respirations for at least 30 seconds, if not a full minute, because they're just so irregular at this age with respiratory rate. After you do that, then you can do, carry on with your assessment. It's also a good idea while they're quiet and you've got your stethoscope in your ears to just slide your stethoscope on down to their belly and listen for some bowel sounds. Of course, you have to undress them enough so that you can see. You got to check them for rashes. You need to look at their work of breathing, if they're retracting at all, which we're going to get into in the respiratory chapter soon. Oh, there you go. So, can y'all hear that?
Yes.
Okay, that's my audio for the little baby noises that they make while you're trying to listen to them. So you might think, oh yeah, this is boring. I know all of this. But try to do it with the baby making those noises. And you're already nervous. And it's not as easy as it looks. But you got to overcome that and be able to separate what you're hearing on the inside from those noises on the outside. And when I say overcome that, that means recognizing that this is normal. This is normal baby noises. And there's still a heart that's beating, and there's between those normal grunts and groans, they have to breathe. And you just keep your stethoscope in place and stay calm and leave your stethoscope there until you get your numbers. You might have to start over a couple of times, but I'm telling you, it makes everybody nervous. The more you take your stethoscope off and act like you did something wrong and you're upsetting the baby and you keep having to start over, just smile and keep your cool. Start over in your head, but don't make a big deal out of it on the outside. Just keep your stethoscope there, put your hand on the baby's back, talk little soothing, soft words to them, and just keep watching your clock and starting over as many times as you need to until you get it done. So what if they're crying? How do you count respirations if they're crying?
You don't.
Well, that's true, because are you going to get an accurate assessment of their respiratory rate if they're crying?
No.
But can you listen to breath sounds if they're crying? Why couldn't you?
Yeah.
They gotta they gotta breathe. They gotta take good, and in fact, those are good deep breaths. If they're in between screams, they're gonna be taking big deep breaths. So you can for sure make sure that they're moving air in all their lung fields, and if they are wheezing or have any crackles or anything, you'll be able to get a glimpse of that. And then, of course, once they're calm, you'll go back and reassess and get a respiratory rate when they're calm, if possible, so that it'll be more accurate. So you can hear each one of those. pauses where you could assess their breath sounds. Do you understand what I'm saying when their respiratory rate wouldn't be accurate?
Yes.
What's the point? If you've got to get vital signs on admission and then every 4 hours, what's the point of recording those numbers?
Well, you want a baseline. If you're getting inaccurate information, that's not really helping you.
Right. And every 4 hours, if it's inaccurate, that's not going to be an accurate trend. You know, if you just look at the numbers, they're going to say, well, why did their respiratory rate go from 30 to 72? Oh, they were just crying. Well, why didn't you wait and reassess in 10 minutes when they quit crying? That you just wasted, you know, an opportunity for valuable data. So the toddler, this is when, so it says incorporate play into the examination. That's not exactly the same thing as a game. There was a test question. Don't remember if it was on our test or if I had just seen it. And the correct age group to incorporate a game into the assessment would be a preschooler, but the toddler is more just playing. They may not be able to cooperate with a game and follow instructions for a game. And I know that sounds like a trick question, but try to make that make sense to you. They want to play, but that means they want whatever you have and they want to play with it. They don't want to follow your rules to play a game. You can still let them sit in the caregiver's lap if they want to. Sometimes they're running around the room and they're in a good mood. Other times, especially if they're sick, they can be very, have a very high stranger anxiety and really not want anything to do with you. And that's what you have to deal with sometimes. So, okay, that's enough of that. Now, preschooler, why do I have this picture on there? Think about our stages, their imagination, their magical thinking, anything is possible. There's fairies around every turn. I think sometimes I have the mind of a preschooler. They fear body invasion and mutilation. When you say they're going for a CAT scan, they think of their cat at home and what in the world you're about to do to them and their cat. If you say, I need to take your blood pressure, they hear you say, take their blood. Things that we just take for granted, they can really come up with some new meanings. But they have that sense of initiative that if you explain to them and what's going on in the right wording, you can elicit their cooperation because they want to be a part of what's going on. They want to cooperate. They want to know, but they're very easily frightened. So you've got to explain things the right way. I don't know if I can deal with any more of the screaming. That's enough of that. This is probably my least favorite age, the school ager. They can be little turds or they can be a great joy. It just depends. The most difficult patients for me are the school age kids that maybe have a touch of ADD, maybe have a little bit of autism. I don't know. There's just some different, the parenting issues sometimes make the family dynamics is unusual. It seems like no matter what you do, you can't get cooperation. That's why I dread it. The younger kids, I feel like I can just pick them up and love on them enough until they'll cooperate with me. And that just may be totally wrong. But what can I do with him, with this little boy in this picture? What can I do? I can't act like a child molester and just go start squeezing on him. That's what I want to do, but I can't. So it's just hard for me with this age.
I mean, maybe you could like get on their level. A lot of kids like these Xbox stuff, I know nothing
Yeah.
about them.
Yeah.
You know,
Yeah. I mean,
Chargers,
that's all you can do. And it's just, takes a little more thought, I guess. That's what makes it harder. It just takes a little more effort than squeezing them. They're very concrete. They're realistic as far as, don't lie to them. They, especially if they've been in the hospital before, they know what's coming and they're watching for lies. So just always be honest. Respecting privacy is a big deal, especially with members of the opposite sex. And sometimes we forget about that. And you can just send them over the edge by walking in when their gown is not completely, secure behind them and their booty shows or something like that. It can just be utterly humiliating to this age group. What are you doing? Yeah. So that is the school age kid that I have a hard time with. I have heard screams like that so many times, and it breaks my heart because I don't want them to be that afraid. But when they get themselves worked up to that point and they're of that age, it's not like they're too young to understand. I don't know. It upsets me, and I don't know how to. And you know what? A lot of times, this is why I said about the parenting and the family dynamics. If it was just me and the kid, or the nurse and the kid, I think a lot of that wouldn't happen. But I think the family dynamics in the room and that comes from home exacerbates the stressful reactions that the kids have in the hospital, their display of emotions when obviously they're stressed and the family's stressed, and you get this emotional situation going on. I really think they play off of each other. And if we could just get out of, I call it mommy syndrome, kick mom and dad out of the room and just let me talk to the kid, we wouldn't have that. Okay, let's see. Teenager, they're pretty easy. It's just that you never know if they're just playing the game and playing along with you, or if, you don't know what they're really thinking about you. That's what always kind of embarrasses me. I think they like me, but really they're like, not her again. She's back. Privacy. Yeah, they expect privacy. They expect for you to respect them. You to treat them like an adult, because teenagers think they are adults and they expect for you to treat them as one. Whenever you go to do your exam, it changes from when it's a baby, a toddler, a preschooler, and you've got to expose the chest to look for work of breathing. You got to think twice before you go exposing the chest of some of these teenagers. So you just have to be careful the way you do things. But for the most part, it can be similar to your assessment of an adult. It's just the mental aspect of knowing that they're not an adult. Even though they want to be, they're still a child on the inside. So we have to recognize that without making them think that we recognize it. we got to let them think that we think they're grown.
There are times that I just really hate him. It's like I don't even matter anymore. You know how much that sucks? After everything I gave him? I mean, all I ever did was think of him. Text him, call him.
Okay, anyway, so that's the drama with the teenagers that was my example, but anyway. So you're preparing to assess the lung sounds of a 3-month-old sleeping infant who is being held on her belly by her mother against the mom's chest. Which technique should the nurse use to obtain an accurate assessment? So 3-month-old is asleep. She's on her belly against the mom's chest. What do? Do you turn the baby on her back prior to beginning the assessment? Yes or no?
No.
No.
Okay.
No.
warm the stethoscope before placing it on the infant's shirt.
Yes.
Assess the lungs from the apex to the base bilaterally.
Why not?
Why not? Can you? If she's
Yeah.
laying on her stomach on mom's chest.
No, you're gonna oscillate from the back.
Well, but can you listen to lung sounds on a baby with them laying? Well, yeah, you can, huh? You can listen to the backside.
Mhm.
Apples to apples, oranges to oranges, bilaterally, without turning them around. Identify the hyperresonance heard as normal because of the thin chest wall. Place the infant flat while listening to the lungs. Auscultate the lung sounds through her back. Let's see what it says. So we're listening to the lungs from apex to base bilaterally. We identify the hyperresonance as normal. We auscultate through her back. So the reason it said that B was not correct was warm the stethoscope head before placing it on the infant's shirt. And that is a trick question because I think B is correct, but something about that they didn't like. I think it's because it says on the infant shirt.
It doesn't say the skin.
Yeah, but that's still what I do. I don't, and you'll see the doctors do that as well.
Y'all probably do it from like just repetitive, you know, just
Well,
always
I mean,
wanting to put it on them.
And I know in the video that we had to watch before clinicals, it said to put it underneath the baby shirt, but then you told me in clinicals to put it over the baby shirt.
just to try to keep them from crying, because it's not, you can still hear. If they've got a onesie on, those thin little outfits, there's no reason to arouse them. Just, you know, if you put it under their shirt, you're going to have a screaming baby or a crying wiggly baby, and it messes up your vitals, it messes up everything, and you can still hear. Now, if you're trying to put the stethoscope over their clothes and listen, and they have a wool fleece Old Navy jumper on, then yeah, you might not be able to hear. So it just, again, that's your judgment. It's common sense. The book wants you to put it on their skin. In clinical, I'm going to cringe if you wake up the baby just so you can put it on their skin when there was no need to do that, because try it my way first and you'll see that most of the time it works. Just put it through their clothes.
It does work.
Yeah, it works fine. There's no reason to wake them up, but that's, I guess, too risky to put that in a book. So they're just going to tell you to make sure you put it on their skin so that you can hear good. So testing purposes, is it under the shirt? It won't be on the test. I would not do that. If it is, then I'll throw it out. But yeah, testing purposes. Do what?
I do have a question. So what if they're like, the 3-month is just naked and with their diaper on? I see some doctors put like the gloves on the stethoscope and do it without.
That's a good question. If they're already naked, then I'm going to I don't ever use anything in between their skin and the stethoscope. I just warm the head of the stethoscope in my hands first.
Okay.
It's just what I'm talking about listening through the shirt is for the baby that's asleep, and I'm trying not to wake them up. That's the only time. Yeah. But yeah, if you were to see something like this on NCLEX, the best answer is always skin to skin. Not skin to skin, but stethoscope to skin. 4-month-old is sleeping during their checkup. Which assessment do you do first? Inspection, palpation, percussion, auscultation?
I would do the auscultation or inspection.
Anybody else?
I would do inspection.
Well, I mean, inspection you would do, but as far as inspection, are you saying like inspect like the whole body, or just as you see them coming in?
So my first thought is inspection is just using my eyes to look and make a visual assessment.
Doesn't that include the diaper area though?
Yeah, technically that's inspection of everything. So do they mean a general impression inspection or a full inspection? So let's see what it wants us to say. It wants us to auscultate. So y'all are on the right track. Does anyone have their book in front of them?
I do.
Look at page 720 and see if you see something called a critical thinking exercise on page 720.
Yes.
Okay, so everybody write that down. Page 720, read the critical thinking exercise. We don't have time to do it right now though. Nurse is performing a physical assessment of a 16-year-old girl. Which of the following is a recommended guideline for interviewing at this age or developmental stage? During the interview, ask the caregiver to answer any questions that the teenager's too embarrassed to answer. Nah, probably not. Keep up a running dialogue with the caregiver, explaining each step as it is performed. What's wrong with that statement?
You need to talk to the patient, not the caregiver.
Right. Perform the genital exam first. Explain to the caregiver that the teen needs privacy and ask him or her to wait outside the room. So some of these questions are so easy. That's not even, like that wasn't even hard to choose the right answer. Hopefully you would never see one this easy on the test. Is there any questions about this one? Why A, B, or C is wrong? Okay.
I do not about the question. So let's say you're in a situation where you do ask the parents to do that and they refuse.
So I've never honestly asked the parents to leave. What I have asked is I've asked the teenager, would you like for us to do this privately? Would you like for me to get everybody to step out before say it's a girl that is has big bosoms and she has an abscess in her armpit, and because we get those a lot, the staph infections, maybe she has some kind of abscess and we're going to need to get her shirt down and it's going to expose her to a degree. Or maybe it's in her groin area or her buttocks, the top of the buttocks, they get abscesses there. So there's been quite a few opportunities where I would not feel uncomfortable saying, hey, do you want me to get everybody to step out? Because I need to check your wound, okay? And I just kind of offer and make it like it's not a big deal to kick them out. Like I do this all the time. We're going to kick them out so I can check your wound real quick, okay? Okay. And the parents just get up and walk out. Like it's not a big deal, you know? But as far as the tense, I think that I need to ask you and dad to step out so I can ask your daughter or son some personal questions. I've never had to do anything like that.
Okay.
I actually have a question about
Uh-huh.
just like teenage females in general being a male. And it might be a no-brainer answer, it might be in the book, but I haven't looked at any of that yet. But would you, as a male, ask a teenage female if you would like a female to do it, if you have to examine anything like that?
Yeah.
Okay.
Yeah. And I'm pretty sure there's, actually, I don't know that there's policy for that, but I would think that the charge nurse in making assignments would consider that sort of thing. But I do know that when we have had a male nurse take care of a female patient that needs an in and out cath, that I've seen him go to a female coworker and ask if they could do that for him. Just to
required to have a chaperone.
They may be. I just don't, I can't picture, I've gone through the policies up there so many times and I can't picture in my mind a policy that states that. If it's there, maybe it's just an ethical thing, that it's just something that we just assume. But I mean, because we're not talking about doctors and female patients. We're talking about the nurse. I just don't know. I don't know if it was out of respect that the male nurse got the female nurse or if it was a rule. I don't know. Have y'all talked about that somewhere in another class for your adult patients?
No.
I haven't talked about it in another class, but just from work experience, working at Quick Care, I know if there was a male provider, then a female nurse had to escort, whether it was an adult patient or a minor patient.
I'm pretty sure Willis Knighton has a policy that if it's going to be anything invasive or if they're going to get undressed, that a male has to have a female chaperone, and if it's a female nurse,
Gosh.
they have to have a male chaperone.
What's wrong with you? Speak quiet.
So that's a good thing to clarify next time we're in clinical. If someone reminds me, we can ask on the peds floor how they handle that and if there is a policy. Okay, so I wanted to show you this real quick. This is what, the reason I posted this to the clinical module is just so you could see in each of the patient's rooms, they have their own monitor. So there's no need to carry the vital sign cart into the rooms to get your vitals. You just turn the monitor on if it's not already on and get your blood pressure and pulse ox. You're going to manually auscultate your respiratory rate and your apical pulse. For sure, you auscultate your apical pulse. The respiratory rate, you can do it a variety of ways. If you can see them breathing well enough, then you can count it that way. You can put your hand on their belly, you can put your hand on their back, or you can use your stethoscope. Every time I try to do it any other way besides with my stethoscope, I end up having to start over. So my preferred way is with the stethoscope, but it's whatever works in the moment for you. And then we have the oral axillary thermometers. We used to have a tympanic, but that broke. The temporal we got rid of. Some of the doctors did not like the readings. And you know, they don't work if your kid's diaphoretic, if they've been laying on that side of the head. They're just too iffy. Axillary works on everybody. So oral axillary we use a lot. Then we also have these disposable thermometers. If they're on any kind of contact precautions, we can go get one of those and leave it in their room. Here's a variety of the types of blood pressure cuffs that we have. We have the little orange one for the babies, and it has a picture on it, so you'll know this one's for the babies, this one's for the toddlers. It has a kid crawling on it. This is the small adult and then the large adult. And then be sure that you document which extremity you get it on. So in this picture, you can see how they put the blood pressure cuff on the lower extremity of the baby, and it's way easier to get it on the lower part of their leg than it is to go up here at the top and get it, you know, here it's gonna rub on their chest. And it's just, you have to pull that arm out and, you know, separate it from the chest wall so that you can wrap the cuff around. And it's nearly impossible to do that without waking them up or having them fight against you or scaring them. But sometimes you could almost sneak it on their lower extremities. So I understand why we do it there. Just be aware, if your number is erroneous, then you need to check it in the right upper extremity. Pulse ox probes, there's lots of different places we can put it. You can wrap it around the top of the foot. The fingers and the toes are okay, especially on the bigger kids. But on the little hands and feet, I like to go around the top of the foot. You can go around their little wrist. Whatever you do, once you get it in place where it starts to detect a waveform, hold still. Keep it in place, keep it, because normally the number, if your very first reading is like 92, the number is going to go up probably to 98. So just hold still. Make sure you have a good waveform and your heart rate correlates with your assessment of what their heart rate should be. These are what our neonatal electrodes like. We have a package called neonatal EKG or neonatal electrodes maybe. So you've got your white, your black, and your red. White on right, smoke over fire. 3 leads, that's all we use on the floor. White on right, smoke over fire. It does tell you on, you know, where to plug them in on the cable and where to place them on the body. But if you can remember white on right and do that one first, then smoke over fire comes easy. All the kids are not on the monitor. If they have an order to be on the cardiorespiratory monitor or CRM, then this is what we'll put them on. Many of them are, but many of them are not. Some are just on a continuous pulse ox. So we wouldn't have them connected to the chest leads. We would just have them on a pulse ox with the same equipment that's in the room. It's connected to the big monitor on the wall. For your pain scales, we use 3 different pain scales. Numeric, if they can answer 1 through 10. Faces, where you have to have the Wong-Baker faces to show them, and the child has to point to which face they are. You cannot look at their face and assign them a number based on their facial expression. That is not what the faces scale is. This is a self-reporting scale. So if they're smiling, but they point to the number 6, that's the way they feel on the inside. What they're doing on the outside that you see is a coping mechanism. So faces is, they have to see that. You have to show it to them. So numeric, faces, and then if they are nonverbal, which means they cannot answer you verbally, whether it's because of their developmental stage or because they're asleep, then you can use the FLAC scale: faces, legs, activity, cry, and consolability. And I give you a handout. It's on Canvas. So that after you get done assessing your child, you come out and you look at your chart, your FLAC scale, and you assign them a point for each one of those things, and you get a number. Always document which scale you used to obtain your score. Whether they have pain or they don't have pain, it's a vital sign. You check it every 4 hours and more often if needed. So you guys did your growth chart challenge. So we don't have to do this, but this is where I know the growth charts I gave you were separate for length, weight, and head circumference. But normally they're all combined with the length being represented up here, the weight is here, and then if you flip the chart over, it will have head circumference on the back. And, you know, someone asked about, you know, what do I tell the parents? Because their kid's way down here at the 5th percentile, and that seems like they're almost off the chart. You know, what do I say? Well, it's hard to know what to say unless you had a trend. That's what we do with the growth chart. We trend them. So if your baby pops out with a big head and a big body, it's just a big old baby, and they plot at the 95th percentile, then we would expect at their 1 month visit that they're still at the 95th. And at their 6 month visit, they're still at the 95th or around that. They're going to follow that trend. If suddenly they drop off, then that's when we know we have a problem. In fact, we would say, is daddy big? Like if you had a 95th percentile baby, the doctor would say something like, is dad big? It's, oh yeah, he's 6'4", 240 pounds. Well, it looks like you've got a big strapping boy. I bet he's going to take after dad. That's all I would say with the baby in the 95th until we trend them and just watch and see. Same thing goes with the 5th percentile. I've heard the doctor say things like, well, mama, look, you're real petite, you're little. Your husband's what? He's like 5'8", 170 pounds. So, you know, it's just genetic. You're just going to have a petite little baby or something like that. And that's what you assume until the evidence shows you different. It doesn't matter where they fall as long as they follow the same trend and they're within range. Does that make sense?
Yes.
Okay.
Yes.
Okay. Do you remember how to convert 17.5 pounds to kilos?
Divide 2.2.
Good. So we have, this is what our scales look like if we have to weigh a baby on admit or for a daily weight. We have each of these scales. I put a blanket on the scale and one dry diaper, whatever size diaper they're in, zero the scale, take away the diaper. Okay, so now I'm left with a scale and a blanket. Then I take my baby, I get them naked, and I have them in a clean, dry diaper. I've already accounted for the weight of that diaper. And then I put the baby on the scale. I get their weight in pounds and kilos, because parents speak pounds, but I need kilos. I never do this alone. Always have a helper in the room, just in case the child decides to jump for it. This is a diaper scale. If they're on strict INO, we'll have this in the room. Usually 1 gram equals 1 milliliter. So if you weigh a diaper, you have to have one clean, dry diaper. If they're in size 2, then you're going to zero the scale with a clean, dry size 2. Then you put your dirty diaper or wet diaper on the scale. If you get 42 grams, that is equivalent to 42 milliliters of urine. So that's how we do strict INO on babies. As far as measurements, we get head circumference on everyone 2 and under. And abdominal circumference is on an as needed basis. If your child is admitted with abdominal distension, of course, it's a good idea to do it just to have a baseline. Otherwise, it's kind of a nursing judgment or as ordered thing. And chest circumference, the same thing there. We don't routinely get chest circumference unless it's ordered. It's just height, weight, head circumference less than 2. So this is a picture of, on the top, of sarcomoral cyanosis. Hopefully you can see how they're a little dusky around their mouth. And then the bottom picture is supposed to represent paleness. Those lips look pale. What you want is pink, warm, dry. That's what I want to see documented. That's what I want to see assessed. If you don't say pink, then that must be because they are some other color. And I'm going to want an explanation. If you say that they're not warm, that's because they're cool or they're hot. If they're cool, is it because the air conditioners, cut down too low, and they need more covers? Or is it because there's a perfusion issue? If they're hot, does that mean they're running fever? Have they been treated for fever? They should be dry. If they're not dry, they must be clammy or diaphoretic. Are they having a heart attack? Are they in pain? Why are they are they nauseated? Why are they diaphoretic? Oh, I didn't mean they're diaphoretic. They're not diaphoretic. They're just not dry. Well, greasy teenagers don't count. They're still dry. Because the reason we're asking skin, pink, warm, dry is because we want to know about perfusion and we want to know if they're diaphoretic. So if they are pale, cool, clammy, diaphoretic, hot, that's fine to document. flushed, hot, moist. You can document those things if that's the truth. But you've got to be aware that what you're documenting is not normal. And most likely you're going to need to elaborate and explain how you intervened and what you did. Any birthmarks, any stork bites, hemangiomas, Mongolian spots, scarring that is obvious, take note of and document. Everyone knows what a Mongolian spot is, right?
I don't.
Yeah, it's like it looks like a bruise, but it's not.
So yeah, it's usually found on the buttocks and back area of dark-skinned babies or children, and it looks like a big bruise. And so if you don't, if you see something that has that greenish blue bruised looking tint to it on the back or buttock area of the dark-skinned baby, then before you assume that they got whacked with a belt, ask the parent, were they born with this mark, with this spot right here? Or is this something new? And they'll say, oh yeah, that's a Mongolian spot. Because the parents, trust me, they know, they've been accused, they've gotten the stares that they're beating their child. They are very aware of what a Mongolian spot is, and they will readily educate you. So be aware.
I have a question.
Uh-huh.
So if it's like an African American baby or a darker complected baby, what do we say instead of pink, warm, and dry?
They're still pink, warm, and dry. What should be pink is still pink. The palms of their hands, the soles of their feet, their lips, their mucous membranes are still pink. So the fact that DocuCare and most documentation tools have appropriate for ethnicity on it, that fact ticks me off, because that has nothing to do with my assessment. I don't care how good their tan is. What should be pink is still pink on every human being. And maybe that's just me, but it drives me insane. Thank you for bringing that up. All of you that are African American, look at your palms. Stick your tongue out, the inside of your lips. Everything that should be pink and well perfused is pink. The nail beds, y'all, they're still pink. That's what we're assessing. So you can check appropriate for ethnicity if you want to, but don't stop there, because I don't care what their ethnicity is when I'm assessing their perfusion. Tell me more. Hope that makes sense. Does anyone not understand? Like, picture yourself assessing an African American patient. Would you know where to look to see if they're pink or not?
That was a good explanation. Thank you.
I'm sorry. I hope I wasn't being ugly. I didn't mean to be ugly. It drives me. I wasn't trying to be ugly. It makes me mad though, because it's like, it makes me mad because it seems to be a universal problem. It's like, what do you people not get? That's not why they're asking what color is their skin. It's not so I can identify you in a lineup. It's so I can assess your perfusion.
No, you actually explained it very well, because I did not understand it until right now. I was literally taking it for face value. Are they appropriately colored for their ethnicity?
No, and the reason that no one helps explain it when they put things on the documentation tools that say appropriate for ethnicity, that just adds to the confusion, because so what if I said, no, Monica, you're really not appropriate for your ethnicity. What the heck? I don't know your that's so stupid.
I agree. I think I'm a little pale.
I know. I mean, it's just weird. So anyway, yeah, I always enjoy ranting about that for a minute. So we talked about Mongolian spots, hemangiomas, nevi, they look like a little brown crusty lesions, rashes, any areas where their pigmentation has changed that looks unusual, whether it's gotten lighter or darker. And a lot of those things are just things that you're born with. What you may not be born with is the rash and the modeling. Have you seen maybe on yourself, on your thighs, where you model if you get cold, where you get blotchy?
Yes.
Okay, that's modeling. And that can be normal in many of us. When it's not okay is in somebody that does not normally model. And all of a sudden, they're blotchy all over in combination with other symptoms of poor perfusion and illness. When I had pneumonia, I remember getting out of the bathtub, and I had been sick for a while and had been to the ER once or twice, but I was still at home. And when I was in the tub, I looked at my legs, and it was just a pinkish purple maze of modeling, and I don't ever model like that. And then I got out, and I was looking in the mirror at my arm, and just at the modeling on my arm and the slow cap refill, and I'm just shaking my head thinking, I'm gonna die out here in Myra, and no one believes me. No one believes me how sick I am. I was like, oh my gosh, I'm gonna die, look at me. And sure enough, I was in the hospital for a week once I finally got admitted. But Jeff Anderson, the paramedic instructor, came to the hospital to see me that time, and I said, Jeff, look at my legs, and raised my gown up. And he was like, not, like bad, raised my gown up, but enough so that he could see. And he was like, I should have brought my camera. That's the best picture of modeling I've ever seen. So when I see modeling on a baby or a child, I always ask the parents, do they always do this when they get cold, or have you ever seen their skin look this blotchy color before? And if they say, oh yeah, they always do that, then I'm not going to panic. But if they say, no, I've never seen their skin that way, and I know that the child looks ill, then it means more to me then. True or false? The nurse is examining an infant and documents cyanosis. This condition is a decreased pinkness in light-skinned children and an ashy gray color in dark-skinned children, caused by anemia, shock, fever, or syncope.
I mean, I think you would see bluish, not just reduced pink.
So what would you call, if you have decreased pinkness, what would you call that?
Pale.
So good. So yeah, cyanosis is going to have the bluishness. Pallor or pale is what we're looking for. So what stands out to me here is in the dark-skinned children, pallor can be described as ashy gray color. So when you think about looking at your lips, your palms, your soles of your feet, you get more of that, instead of a pretty pink, and it's not an obvious blue, but it's not an obvious pink, you get that ashy gray color. That's your pallor or paleness. The gums will look that way when they're pale as well. Fontanelles. You can see the anterior fontanelle, the little triangle here. A lot of times, if I assess a fontanelle and it feels a little bit sunken, especially when I was new to assessing fontanelles, to me it seems sunken, but I knew there was no reason it should be sunken. So I learned that by asking the parents, is this the way their fontanelle always feels? Then I would be more confident saying soft and flat instead of sunken. And they're like, oh yeah, it's always like that. It's learning by practice. The more normal fontanelles you feel, the easier it is to recognize when one is truly sunken. The book sometimes says firm and flat is normal. I don't like the word firm because it's too close to tense or bulging, which is abnormal. Firm and flat, according to some texts, is considered normal. I say, and what I see other practitioners say, is soft and flat. So what's not normal is to be sunken, It's not normal to be tense or bulging. Tense meaning tight. Tense, tight, firm. All of those three words sound alarming to me. They don't mean firm in a bad sense here, but to me, it sounds bad. It could be confusing. So I stick with soft and flat.
Do you just run your hand across the top of their head?
Exactly.
Just like any kind of pressure?
No, you don't have to. You just gently well, when I say pet them, it's like I'm feeling how soft their little baby hair is and their little soft head, and just it's almost like a handshake to an adult or a hand squeeze to an older child when you walk up and you're greeting them and you put your hand on their hand and you're feeling their skin temperature and feeling that radial pulse and stuff. It's like that. It's how I begin my skin assessment. I just stroke the top of their head. I'm feeling skin temperature. I'm petting them and oohing and eyeing over them, and you can easily feel that anterior fontanelle. You do not have to apply any pressure. You just run your hand over their head. And the families usually don't even realize what you're doing because you're just cooing and, goo goo gaga over the baby. The posterior fontanelle, you do not have to assess. I know it has it on DocuCare, but you do not have to assess posterior fontanelle. It closes early, and we don't worry about that one. Head shape terminology on page 726. Please review the different types of head shapes.
I'm sorry, can you repeat the page number?
726. For eye assessment, if you didn't assess the A for accommodation because of their age or whatever the reason, or you forgot what the A meant, y'all, that was me. The first year or two of my practice, I always felt like I was lying if I said Perla because I couldn't remember what A meant and I was too embarrassed to ask anybody. And when I finally said something about it, the nurse, this was pre, internet on your phone days, the nurse said, if you don't know what it means, just leave the A off. Just say Pearl. She said, I do that sometimes if I don't assess accommodation. I'm like, oh, okay. Don't lie. If you didn't assess it or you didn't understand what it was, don't document it. So pupils equal, round, reactive, and did they accommodate? As far as, take note here where it says equal, round, and reactive. What I was seeing on DocuCare was that people were writing equal and the size, but they weren't writing the reaction time. You've got to say if they reacted, and it's easy. Either they did or they didn't. Either they're brisk or they're sluggish. If they're sluggish, we've got a problem. You shouldn't have any patients with sluggish pupils. So be sure you document that as well. So also on DocuCare, there's a column that says both eyes, and then there's a column that says left eye, right eye. If you check the both eyes column, there's no need to do the right and the left. You just have to do one. Take it off or raise it up. That's up to you, and I really don't care. It just depends on the situation. If they're already naked, great. If you can unbutton the shirt and see what you need to see, fine. If you just want to raise it up, fine. Just make sure you look at the chest wall. Page 735 talks about pectus excavatum and pectus carinatum. Please review those terms and understand what they mean. Pectus excavatum is where the chest sinks in, where the sternum sinks in, and they're born that way. And it looks like a terrible sternal retraction. And if they are in any kind of respiratory distress that causes them to have any degree of retractions on top of having pectus excavatum, it's very scary looking and it makes it look worse than it is. I got a kid from PACU after a surgery one time, and they were running for the crash cart because the child looked to be in so much respiratory distress. And then mom came waltzing in and she says, "What's the problem?" And she said, "Oh, she has pectus excavatum. Her chest always is like that." And we felt so ridiculous, but we didn't know. So please look at that. When you raise the shirt up, you can see so much information about their work of breathing. Heart and lung sounds, this should work, hopefully, as a link to take you just to review some heart and lung sounds. You may, to get this link to work, you're probably going to have to open this in PowerPoint mode to get the link to work. So here are some retractions, which, like I said, we're going to look at some more in the respiratory chapter. But here, can you guys see? Are you seeing what I'm seeing? Did I just make it bigger?
Yes.
Okay, good. So see how the center of the chest is sinking in here? That's a sternal retraction. And that's also what pectus excavatum looks like. So you have to combine this with the rest of your assessment to see, is this really a problem or is this a birth defect? So that's a sternal retraction. Here we have intercostal retractions. You can count the ribs or feel the individual ribs, and the negative pressure of breathing, that negative inspiratory force is sucking and pulling on the skin tissue with the work of breathing, causing the retractions. So intercostal, costal is the ribs, and it's in between the ribs. Intercostal. Here we have sternal. Now, what do you call it when you can see the borders of their rib cage here? It reminds me of a turkey, like when you have to stuff a chicken or a turkey or something. When you can see and feel, touch, feel, see the borders of their lower rib cage, those are subcostal retractions. You can also kind of see how you've got an outline from the sternum all the way down. So this kid has some moderate sternal retractions as well as subcostal retractions. They often have more than one type. When you document retractions on DocuCare, it will just say labored, unlabored, retractions. It gives you a checkbox, but that's not good enough. You've got to go up to your notes box and explain, clarify what kind of retractions and how bad are they. That's two things you have to document if your child is having labored breathing. What does that mean? That means they are tachypnic or they're having retractions. You've got to clarify. If they're having retractions, two things: what kind and how bad are they? So if I saw these or the intercostal retractions, I would have to say what kind, and mild, moderate, or severe. Mild, moderate, or severe. Well, how do you know if it's the first time you've ever assessed the child? You have to decide. You have to, the best thing to do would be, when you do rounds, when you get report in the mornings, if you can compare notes with the night shift nurse, that's great. But if not, you just have to make a judgment based on your experience. And if I decide I'm going to call this severe intercostal retractions, then it can only get better from there. But if I'm not sure, hey, you know what, I think this could get worse, but it's pretty bad, then I'm going to say moderate. If I have to raise their shirt up and use my flashlight to look and then look like this and go, are they retracting? Wait, I think they are. Obviously, that's mild. If I'm having to search for it, then it's mild. If I can easily see it, but it could get worse, then it's moderate. And if I don't see how it could be any worse, then it's severe. You've got to label it like that with your first assessment of the day so that you can trend it as the day goes on and you have objective data to prove that they're worse or they're better. And then in this picture, it looks like I can see a little bit of intercostal retractions on the side. And again, I see subcostal retractions. I'm not sure if we have any sternal here or not. I'd have to see this live before I just decided if we had any sternal. If we do, it might just be mild. But I can easily see the outline of that lower rib cage, and I see some skin sinking in here. And a lot of times they air trap, and this belly breathing becomes more exaggerated. It is normal for children to breathe with their abdomen, I think under 6 or 7 years of age. We'll see it in the next chapter, I think, or maybe it's in this chapter. I can't recall, y'all, but you'll find it if you read. It is normal to breathe with abdominal breathing, but sometimes it is so exaggerated that that's the first thing that you notice. If you just can see their belly bouncing in the bed because of they're working so hard to breathe, then it's okay to document exaggerated abdominal breathing noted, just to prove a point that they're working extra hard. Any questions about retractions? Does it talk about this in your chapter? Please pay special attention, because that's to that section about how to document retractions, because this is something that you will definitely need to know. Then again here, other retractions we could have, we have supraclavicular, if it sinks in above your clavicle. Suprasternal, sinks in above your sternum. These would be indicative of an upper airway obstruction. If you have croup or upper airway swelling or an obstruction from an object lodged in the throat, then you might see this type of retraction. Then we have our intercostal between the ribs. Substernal would be below the rib, below the sternum. Sternal would be here, and then subcostal. So you want to learn this terminology so that you can document appropriately. Let's see. And then I think you guys know how to do the belly documentation. When you document your abdomen, be sure that you document 3 things: firmness, tenderness, and shape. What shape is their belly? Is it round? Is it flat? Is it sunken? Is it tender, non-tender? And is it soft, firm? There are more things that you could document. Just make sure you at least have these 3 things. I'm looking on DocuCare for at least 3 check marks: shape, tenderness, and firmness at a minimum. I hope you're taking notes on this stuff, because this will help you in your DocuCare. Range of motion, all I'm going to say about musculoskeletal is when you do range of motion assessments, they should either be active or passive, right? So if a child can move their extremities on their own, then they are capable of active range of motion. If they cannot, then we have to perform passive range of motion. So I glance, when I check that area of DocuCare, I'm glancing down, making sure that you documented whether or not they had active range of motion or passive range of motion. Let's see. For your neurologic assessment, page 745, table 33.3, and box 3310. Y'all got that? 745, table 33.3, and box 3310. Please review that. understand about the Glasgow Coma Scale and that it is a reflection of their neurologic capability, their level of coma. It is not a reflection of if they were awake or asleep when you walked in the room. Can they open their eyes on their own when they want to, when they feel like it? Yes or no? Not did they open their eyes when you walked in the room. So please review the Glasgow Coma Scale. Know how to assess the reflexes in your infants, what's normal and what's not normal from a neurologic standpoint. Understand that if an infant is consolable, that is important. And that's why I'd ask you on DocuCare, if they're crying, are they easily consoled? Because an infant with increased intracranial pressure will be inconsolable and have a high-pitched cry, like a cat. They cannot be consoled. That is a huge red flag when a baby cannot be consoled, either from a neurologic standpoint or some other type of pain. So if you document that your child, cried during the exam or during a procedure, always follow giver or unable to console. So you should follow up on that. And then additional assessments, voids and stools per diaper or bedside commode, their diet, if it's formula, specifically what kind of formula or breast milk or whatever their diet is, and how they're tolerating it. As far as your IV goes, I've shown you a picture here of what a no-no looks like. These Velcro elbow restraints, we use them on one extremity for the purpose of an arm board to help secure the IV site. And when you just use it on one extremity, it is not considered a restraint. And a lot of times also the IVs are very, very wrapped with gauze and we can't see the insertion site. So we would document distal and proximal to that site that the perfusion is adequate. So you should always be able to see your fingers and your toes distal to the site, and you can always assess above the site. So when you come in, you touch and feel and note that their fingers are pink and warm. And every time you come in, you're assessing that that dressing is clean and dry and their fingers are still pink and warm above and below the site as well. Because if the IV starts to infiltrate, then their flesh is going to become cool and puffy and hard. And then always close with safety. Side rails up, bed low and locked. Kids love to press the buttons and get up to the ceiling in those beds. Bed low and locked. Maybe call bell within reach of the caregiver. Caregiver at bedside. It's a security thing that children less than 12 have to have an adult with them at all times. Those are safety issues. So always end your note with something like that. Okay, so let me stop that share and do a new share. Hang on, don't leave me yet.
While you're doing that, I have a question. Are you going to post the slides for chapter 35?
I did, I thought.
No, there's just videos underneath. Whenever you click on the video.
Okay, above the video, isn't there a slide link?
There is. It wasn't there for a while. Then it showed up and it said it was unavailable. But right as we got on the Zoom meeting, I tried it again and it did work.
Okay.
I tried it right before the meeting and it said unauthorized.
I don't know why it does that sometimes, because I re-downloaded it to make sure that it wouldn't do that. So weird.
Maybe try to reload Canvas because it let me print it out. 45 still not showing up, but 35 did.
Yeah, 45's not on there yet. Okay, portion of screen. Got that.
Yeah, I just redid my Canvas and it doesn't show any slides or video. All it shows is the 3 little YouTube videos.
Above the first YouTube video, there's no
There's nothing.
Huh. That's really weird. Look at the, I'll check it in just a second. Can y'all see what I'm sharing right now? Oh no.
Yes.
Yes.
Yeah, you can. Okay. So what I updated last night was just week 4 here, where we are now. So I changed it to the ill child. Ooh, how did I not do this? Ooh, I forgot to go back and do this. Watch this. Brr. Done. This week it's only the ill child. Chapter 35. Your PowerPoint, there's not much to it. It's super simple. My notes are on it when you download it with the presenter notes. There's one little article that's not even really an article. It's more of an editorial that's super interesting. And it goes along more with the chronically ill child, the chapter that we skipped, but I didn't want to skip showing you that because it touched me. It's written from, the mother wrote it from her daughter's perspective, and she has a developmental disability, and just all the things they have been through and the ways that nurses sometimes treat her daughter. It's written from her daughter's perspective. So it's a good read. And please, if you can, go ahead and read chapter 36. I'm just not requiring that since we're trying to get caught up here. The child life video is the last PowerPoint of chapter 35, but I went ahead and added the video separately. So you could, either place you can access it. It's a little 6-minute video that gives you an idea of what child life is meant to do. And then I stuck the IV placement and assessment videos in here, even though they really went more with physical assessment. They could also go with a hospitalized child. You'll see things on the video that are absolutely correct, but might be a little different than the way you learned it in practice, and that's okay. Let me hear everybody say that. That's okay. As long as things, yes, it is. It's okay. Just as long as things make sense, you're going to see, variations in things, but overall, it's pretty much the way that we taught you. So that there's nothing else for you to do this week other than get caught up on your physical assessment reading. And if you haven't done your math, Kaplan, do it. And study your chapter 35 notes and just watch. So next Friday, no. This is confusing me the way I did this. So today's the 11th. So this is right. So we're caught up now, right? Because next Friday would be the 18th. And on that day, yeah. So you're going to watch for me to post chapter 45. And once you get all this other stuff, all this other material, you're organized with all of that, then I want you to move on to chapter 45. For sure by next Friday, you need to have started looking at chapter 45. I'll finish filling this in and post it for you. September 25th is our next test, and it will cover physical assessment, the ill child, and the first part of respiratory. Any questions? The ill child looks like this, and it is only 24 slides, y'all. And when I tell you that it has my notes down here, let me show you. So I say, why would a child be feeling stress in this situation? And we would talk about it. And I list what I'm wanting you to say here. So, I mean, it's really not hard. You good?
Yep.
Yes.
And then at the end, We talk about this is the article, Empowered by Nurses, that I wanted you to read. And that comes from the article. And this is the link to the Child Life video that I've also posted. Okay. Guess that's it. Let me know if you have any questions. I know you were here, Chris. If you still can't get the PowerPoint to print, let me know. Or can't get it to pull up, let me know, and I'll go check it real quick right now.
I think I have another student sending it to me.
Okay.
Thank you.
All right. See y'all later.
Bye.
Bye.